Hi everyone, my name is Allie White and I'm going to be presenting my Capstone project, which is focused on improving smoke evacuation compliance in the operating room. I completed my project at a community hospital in northern New Jersey. This hospital has 6 operating rooms that perform a variety of surgeries, including general, robotic, orthopedic, neurosurgery, and vascular surgery. Although smoke evacuation machines and cautery are available in each of the operating rooms, they're not being consistently used, which created an opportunity for a quality improvement project. The main problem that I found was inconsistent use of smoke evacuation, even though the smoke evacuator machine was in the room. There are a couple of barriers that were associated with this. The cautery pencil included in the surgical packs were not compatible with the smoke evacuation system. Staff had to open a separate pencil, which they may choose not to do. Tubing was often too short or too short to easily reach the machine, and some surgeons reported that the machine was too noisy. These barriers led to inconsistent compliance and increased exposure to surgical smoke. To get a sense of what the staff knew, I did a quick informal questionnaire during the morning huddle. I asked staff when they thought that smoke evacuation should be used during surgery, and many of their answers were just saying that they thought that smoke evacuation should be used only for open surgeries, even though it's actually recommended for any procedure that creates surgical smoke. Most staff members knew that the smoke wasn't healthy and that it could cause cancer, but they didn't realize that it could also cause breathing problems and even carry viruses. It's important to know that the smoke evacuation isn't best practice, it's actually a required law here in New Jersey since 2023. This law mandates that smoke evacuation must be used for all procedures that create surgical smoke. And this helps protect staff from long term health risks like respiratory issues, exposure to carcinogens, and the potential for viral transmission. Not complying with this is not just a safety issue, it could also have legal consequences, including fines, violations, and hospital liability. So, following smoke evacuation guidelines isn't optional, it's a part of keeping the staff and the patients safe and meeting both the state and national standards for workplace safety. The people involved in this project are the operating room nurses and surgical techs who are responsible for setting up the case and ensuring patient safety. The surgeons are the biggest influence. They're the ones who often are asking for the smoke evacuation cautery, or they don't want to use it because they complain that it's either too bulky or too noisy. So, gaining their support in the use of smoke evacuation cautery and equipment is really important for compliance. And the OR nurse manager and perioperative director are part of the leadership team, and they are important because they will support the use of the equipment. And lastly, patients are also stakeholders because they will benefit from a safer OR environment. This project is guided by the theory of planned behavior, which helps us understand why people do or do not follow a behavior. And according to this theory, behavior is influenced by 3 main things. The first one is attitudes, how staff feel about using the smoke evacuation equipment and whether they think it's important. Second is subjective norms. This is the influence of peers and surgeons. If their colleagues or surgeons don't support using this equipment, the staff is going to be less likely to use it. And third, perceived behavior control. That's how confident the staff feel about using the smoke evacuation equipment. So, for example, short cords or unfamiliar pencils can reduce their confidence and make them less likely to use it. So, by understanding these factors, I was able to design education and practical interventions that would help improve compliance. Surgical smoke contains harmful chemicals, carcinogens, and viruses. Breathing it in can cause headaches and irritate the respiratory system. It was also surprising to learn that exposure to surgical smoke has been compared to smoking 27 to 30 unfiltered cigarettes a day. And despite all these risks, smoke evacuation systems are still not being used as often as they should be. And this is because of staff attitudes, their heavy workloads, and issues like noise and discomfort with the equipment getting in the way. To improve compliance, I am going to do education about the risks and making sure that the right equipment is available and easy to use. To improve compliance, I did education at one of the weekly in-services for staff, and I talked about the risks of surgical smoke and reviewing the regulatory requirements of the state of New Jersey. I also spent time observing surgeries and addressing issues. To address the issues with cord length, I taught staff how to use extension tubing when the cords were too short, and the extension tubing is underneath the smoke evacuator system as pictured in the slide here. For surgeons concerned about noise, I also educated them about using the automatic mode on the smoke evacuation equipment, which only activates when the cautery is in use. And I recommended removing the old non-compatible cautery pencils from the surgical packs so that the correct equipment would always be available. My approach was supportive and education focused rather than punitive. I encouraged staff engagement and made sure that everyone felt comfortable asking questions. And I observed surgeries. I made it clear to staff that I wasn't reporting them to get them in trouble. If they weren't using the smoke evacuator, I just told them what my goal was and that I was just simply there to gather information for my research and ensure a safe environment and provide education if they needed it. I also focus on surgeon compliance. To help with this, I work closely with my preceptor to talk to the chief of surgery and explain to him how important smoke evacuation is and tried to get him to get his surgeons on board with using smoke evacuation consistently. I encourage staff to take responsibility for both patient safety and their own health. I explained that surgical smoke is a daily risk that we are exposed to in the OR. I showed them how to use the smoke evacuation equipment, explained the risks, and helped solve common issues like the short cords. I stress that smoke evacuation is part of the standard of care, and I work to create a supportive environment where staff felt comfortable asking me questions and learning together, focusing on safety and not blaming anyone for not using it. The main outcomes for this project that I focused on were to have at least 95% of staff be able to verbalize understanding of smoke evacuation protocols after I did the education. And then I also aim to have 75% of surgeries consistently use smoke evacuation equipment. And the last goal was to increase the overall compliance by 20% over the course of the project. And these outcomes were measured over the 14-week period. To evaluate the outcomes, I used a combination of informal assessments and direct observation. Instead of a formal test, I did a brief questionnaire during the morning huddle to assess staff knowledge before and after my education. This included asking staff about when the smoke evacuation should be used and the risks associated with the surgical smoke. I also directly observed surgeries to see if they were using the appropriate equipment. And this allowed me to compare the practice from before and after my interventions and also identify any ongoing barriers. I also made sure that equipment availability was always there, and as well as the extension tubing, and also this helped me evaluate changes in both staff knowledge and their compliance over the time period. Overall, the project showed positive outcomes. There was a noticeable increase in staff awareness of the risks associated with surgical smoke. Many staff members were able to recognize that the risks go beyond just cancer and include respiratory issues and the potential for viral exposure. Knowledge also improved, which was reflected in the post-assessment questionnaire that I did during morning huddle. Staff were better able to identify when smoke evacuation equipment should be used and why it's important. I also observed an increase in the use of smoke evacuation equipment during procedures, and compliance improved when I implemented practical solutions, such as showing them how to use the extension tubing and also using the automatic mode to reduce noise. However, there's still an ongoing barrier happening, and that's the non-compatible cautery pencil that's included in the surgical packs. Um, I spoke with my preceptor, who's the OR manager, and they're working on trying to get that non-compatible cautery pencil out of the pack so it's less convenient for staff to use it. This project was important for the organization in a few different ways. First, it helps improve safety for both staff and patients by reducing exposure to surgical smoke, which can be harmful over time. It also helps this hospital stay compliant with the New Jersey law, since smoke evacuation is now required. And another big impact is that it helps make smoke evacuation part of the normal workflow instead of something that's optional or easy to skip. And overall, it helps support the hospital's goal of providing safe, high quality care. In long term, this project helps create more consistent practices and supports changes that can continue even after I have left the facility. Nursing judgment was key in achieving these outcomes. By noticing that smoke evacuation wasn't being used consistently, I identified a safety concern that affects both staff and their patients. I used evidence-based strategies to improve compliance and reduce risk, advocating for safety for everyone in the room. This shows how nurses play a vital role in improving quality and promoting safe practices. This project really shows how nurses play a key role in keeping patients safe, especially from hidden risks like surgical smoke. It highlights the importance of using evidence-based practice in the OR and letting research guide our decisions. It also demonstrates that nurses can lead change and improve practice without having formal authority. I was just coming in there as a master's student, and I was able to educate staff, address any barriers, and advocate for safer workflows. So any nurse can do that. And most importantly, it reinforces that following safety regulations protects not just patients, but the entire surgical team. Surgical smoke is a risk for operating staff everywhere, not just in New Jersey. Using smoke evacuation consistently helps make safety standards for everyone, not just in the OR, but across hospitals everywhere. This project shows that following the best practices benefits both staff and patients, no matter where you are. In this project, I focused on teaching and supporting staff, even without the formal authority, like I mentioned, to help them feel confident using the equipment. I also helped them understand why it matters. I advocated for safer practices and both surgeons and leadership emphasizing the importance of surgical smoke evacuation. I also work closely with the whole OR team, nurses, techs, and leadership to identify and overcome the barriers like equipment issues, and collaborating with the team was key to making a real change. For this project, I used evidence-based practice and quality improvement methods to guide what I was doing and make sure that the changes were backed by research. I also had a lot of practice building my communication skills and leadership skills. I had to work with staff that I didn't usually know, explain why smoke evacuation is important, and guide them towards actually using it consistently. That was a little intimidating at first, but it really helped me grow. And I also worked with my preceptor to talk to the chief of surgery to get surgeons on board, which was really important for making the change stick. Overall, I think this project gave me hands-on experience using my clinical judgment and research to make a real difference and improve the quality and safety of patients and for staff. This project was really meaningful for me personally. It showed me that even the smallest changes, like using extension tubing or putting the cautery on automatic mode, can have a big impact on patient and staff safety. It also pushed me out of my comfort zone. I had to speak with staff that I hadn't worked with before and also approach leadership like the chief of surgery to get support for the changes that I was trying to do. And that was intimidating, but it taught me a lot about communication and leadership in the real setting. And the experience inspired me to keep learning and to think about how I can apply evidence-based practices in my everyday work at my place. And overall, it made me a more confident leader, a stronger communicator, and a stronger advocate for safe patient care. Overall, this project showed that surgical smoke is a real risk that often is overlooked in the OR. Improving compliance isn't just about education, it's about making the equipment easy to use and addressing any barriers. To support the support from surgeons was very important, and leadership played a big role in making these changes successful. At the end of the day, smoke evacuation should be viewed as a standard of care and not optional. Even the smallest changes can make a big difference. And then these are my references.